Welcome to today's briefing on Alzheimer's, the second leading cause of death in California, as you will hear from our speakers. This is the final of 3 briefings we are doing in partnership with the California Department of Healthcare's Take on Alzheimer's campaign, the first campaign in the country aimed at raising public awareness statewide about Alzheimer's, with the goal of encouraging early detection so that Alzheimer patients and their families and caregivers can lead healthier lives. Our first briefing, as our media colleagues will recall, looked at the cultural stigmas that block people from seeking or receiving effective care. Our second briefing looked at the impact of Alzheimer's on women, who make up the majority of Alzheimer's patients, as well as their caregivers. Today, we focus on the challenges of accessing effective care faced by Alzheimer's patients living in isolated rural areas of the state, especially people who live alone without a family caregiver. For many of those people, the one option left to them is a nursing home, often far from their community. In this briefing, we will hear from a public health care official, the director of a nonprofit caregiver resource center, a research and policy advocate, and a family caregiver who will each share their perspective on the needs of people with Alzheimer's, especially in rural areas, and what can be done to bridge the healthcare gaps they face. Our speakers are Dr. Rita Nguyen, Assistant Health Officer for the State of California and Director of Population Health for California Department of Public Health. Carmen Estrada, Executive Director of Inland Caregiver Resource Center based in the Inland Empire. Maria Cortez, a family caregiver for her brother who has Alzheimer's, lives in Glenn County and is a client of the Peg Taylor Center for Adult Day Healthcare in Butte County. And Hagar Dickman, Senior Attorney with Justice in Aging, a national research and policy advocacy agency based in California. Today's briefing is interpreted in Spanish, Mandarin, and Korean, and we will send a recording of the session to all participants this afternoon. If you have questions for the speakers, please enter them in the chat, and we ask our speakers and a special guest we have invited to join, Kendra Adcock, who is Community Engagement Specialist for the very important Alzheimer's Association for Northern California and Northern Nevada, who is based in Butte. Now let's begin. Our first speaker is Dr. Nguyen with the California Department of Public Health, who will give us an overview of Alzheimer's, the challenges in rural California, and the goals of the Take on Alzheimer's campaign. Thank you, Dr. Nguyen, for joining us.
Thank you so much, Sandy, for having me, and thank you to all the media partners and outlets for coming to this briefing today. It's really wonderful for you all to highlight this really important campaign around Alzheimer's awareness and the things that people can be doing to prevent Alzheimer's. And also, once one has a diagnosis, the things we can do to get connected to care, to really plan for the future and care for our loved ones. I know that for a lot of folks, so our data only just very recently showed that Alzheimer's is now the second leading cause of death in California. It used to be the third, and it overtook stroke fairly recently based on our data. And this is projected to double by 2040. So certainly as public health practitioners and as a clinician taking care of patients, Alzheimer's absolutely is something that we need to be aware of, we need to be trying to prevent, and also enabling our communities to have the tools to both prevent and then take care of folks who then have Alzheimer's disease. It's important to know that the primary risk factor for Alzheimer's is age, as one might expect. And California is home to more adults age 65 and over than any other state, highlighting this need for collective awareness, education, and preparation. And I'm so happy to see that the Take on Alzheimer's campaign is the first ever statewide Alzheimer's disease campaign, sort of meeting the need of the day and meeting the need of our future, that we're raising awareness around Alzheimer's disease, how it presents, what people can do to prevent it, and then what to do once you do have your diagnosis. It was developed by the California Department of Public Health to shift public perception, also reduce stigma, to give a message of hope, not one of sort of hopelessness that folks may feel with a new diagnosis. And so by educating Californians about the prevalence, how common it is, where the disparities are, which populations are at higher risk, such as women, communities of color, and rural communities, we're hoping that all can have a better understanding around the risk factors and to reduce the negative impacts that stigma has, which can delay care when folks feel hesitant to seek care and get the diagnosis. As a clinician, I practice internal medicine. Most of my patients are older adults, and it's wonderful to see when families are involved, when patients themselves are asking questions about maybe cognitive decline that they're experiencing or witnessing in their family. For me, that's really the first step to empower people, to really give them this sense of hope that yes, we can tackle this together, we can talk about it. What drove me to public health really is also the opportunity for greater justice and greater equity in health outcomes. And so that's why I'm really thrilled for us to have this rural focused briefing, because what we do see are the disparities that exist in rural communities, founded a lot on the structural differences that exist between urban and rural. I just want to name and acknowledge that we don't have the same resources in rural settings. Healthcare can be hard to come by. The assistance and supports that family can have are far further and further between in rural areas. But these are the things that actually draw me to public health as a clinician, is what can we do to better serve those communities and to better serve those people who are in need of first even being aware of Alzheimer's disease and then feeling empowered to be able to do something about it. And so June is particularly relevant as it is Alzheimer's and Brain Awareness Month. So again, I am grateful for you all to highlight this important topic for Californians, which will increasingly become an important topic as we continue to have an aging population. And again, this Take on Alzheimer's campaign is really starting from a place of empowerment and hope to first know what Alzheimer's is, know how to recognize it, know how to prevent it, and then know how to support ourselves and our family and our community once there is a diagnosis. Rural California is home to 2.3 million residents. It accounts for almost 6% of the state's population. And statewide, California residents tend to be older. The rural residents tend to be older than the urban residents. And when it comes to the impact of Alzheimer's disease on California's rural communities, it's important to understand these geographic, economic, and cultural barriers and equities that can make it harder for families to and for individuals to access resources and a diagnosis. And so really happy to be having this briefing to talk about what does exist, what resources our campaign does elevate, and be connected to others in this space who are doing the work. I also wanted to say that although geographic impacts are certainly something to call out, fear and stigma is something that we want to address with this campaign as well, that this is the second leading cause of death in California. It is a common diagnosis. It is something that probably, like most people, probably know somebody or are connected by 1 to 2 degrees of freedom, knowing someone who has Alzheimer's disease. And we want this campaign to just really name that, to acknowledge it, to not be afraid of it, and that there are so many things that we can do to prevent Alzheimer's. as a clinician and public health professional, one of the greatest things about prevention in this space is that the same things that help prevent Alzheimer's and many cognitive brain diseases are the same things that keep communities healthy. So eating well, staying active, being socially connected, having good sleep, all these things actually help prevent Alzheimer's, and it prevents the diseases that can help accelerate Alzheimer's. So things like cardiovascular disease or diabetes or hypertension, all these things can benefit from the same preventative measures. So it's not as if you're having to do something specific to prevent Alzheimer's. And working on diet, exercise, sleep, social connectivity will help across a number of health outcomes. And so with that, I'm going to turn it back to the rest of the programming. Happy to answer questions. Again, the Take on Alzheimer's campaign, you can find out more at takeonalz.com. And the main things we want Californians to know is that they can recognize the signs of Alzheimer's disease, start a conversation with their friends or loved ones, and then seek out help from a healthcare provider so that we can find ways to reduce and improve brain health before and after a diagnosis. Together, we can take on Alzheimer's.
Thank you very much, Dr. Nguyen. A couple of questions have come in on the chat. I want to ask Sunita Sarabji for your question.
Thank you, Sandy. Dr. Nguyen, so I'm wondering two things. First of all, is there a greater incidence of isolation in rural communities as it relates to older people?
There is, and you can imagine some of that is structural, the distance, the lack of as many community supports and activities. And that is something that we at the California Department of Public Health are looking closely at. Many of you who do follow the trends in public health, behavioral health, which part of that is mental health, is something that we are increasingly doing more work in. We have new funding to address it. And rural communities are one of our priorities for exactly that. The Surgeon General has highlighted the immense impact that loneliness has on health outcomes. And we are trying to find ways to help promote connectivity, have resources. And so that's a really great point. And that is one of the challenges in rural communities. And it's important to name it and then determine countermeasures to help support these communities.
Thank you. And the second part of my question was California's Master Plan on Aging, which was launched 2 years ago. Are there specifics in the plan that address Alzheimer's, and what additionally needs to be in the plan?
Yeah, that's a really great question. Unfortunately, that Master Plan on Aging is not, CDPH is certainly part of it. I'm not in the best position to be most up to date with the plan. Some of my team members may be able to enter in the chat, but happy to follow up and get more information on that.
Right. And I think Carmen Estrada will be speaking a little about that, Sunita, from the standpoint of county and Inland Empire Master Plan on Aging efforts. I'd like
Thank
to—
you, Dr. Nguyen.
Just another question, Dr. Nguyen, is what do you see as the most important resource to build in order to get over the isolation and bridge the gaps in healthcare access for Alzheimer's, people with Alzheimer's in rural areas? What are you most hopeful about can kind of bridge the gap in resources?
Yeah, I'll answer that two-part. I heard a question about isolation and one about healthcare resources. In my visits to rural communities, because we tour different parts of the state to really understand, what has been incredibly striking and inspirational to me is the strength and resilience of a lot of rural communities, that although there may be physical distance between neighbors, oftentimes there is such a strong sense of togetherness and independence in a good way that we as a community can solve, and really trying to capitalize on that inherent community strength and find ways for the community to build and connect. I was in Calaveras County, and they were telling me about a school that had shut down, not enough kids. And yet the community came together and created a co-op. And so opportunities to build things together and solve together, I think, is part of the solution. I think there is a lot of inherent strengths and beauty to the individualism yet connectivity in rural communities, and really capitalizing on the community's strengths and co-solving problems with them, rather than the state coming in and saying, here's how we're going to solve for you. I think really listening and leaning in to the solutions that the community has is probably the best path forward. In terms of building up resources, that is an ongoing effort statewide with our healthcare partners to increase access. I think the advent of telehealth helps a lot in terms of connecting rural communities to clinical resources. I get internet and Wi-Fi can be an issue, and yet telehealth has evolved to just be by phone. The other piece is the California Department of Public Health. We are working to help build up and upskill the primary care system so that folks can get access to Alzheimer's diagnosis and care, even if it's not as easy to get connected to specialists in rural areas.
Thank
So
you.
those are areas that we're trying to work with our partners to augment the infrastructure.
Great. One last question from the chat, by no means the only one, but Macy Yang, your question, just in the interest of time, I'll read it. Is Alzheimer's more prevalent in certain ethnic communities than others?
Yeah, I was going to jump in with that anyway. I think that's such an important question and relevant even for this audience in rural communities. So yes, we see that Black African Americans are 2 times more likely to develop the disease, and Latinos are about 1.5 times more likely to develop the disease than white older adults. And the sort of the underlying reasons for these disparities are in common with rural communities, in that oftentimes what we are seeing is that the underlying drivers of Alzheimer's disease are associated with risk factors like heart disease and hypertension and diabetes, which we also find to be higher in these communities. And when you look at the basis of all that, a lot of that is what I spoke to earlier, the structural inequities. If you're living in communities that don't make it easy for you to exercise or eat well or feel safe because of violence, or you're not socially connected because there isn't a network for, to enable that, these are what we call the underlying social drivers of disease. And as a clinician who takes care of patients who are hospitalized, I see the very end of that. But when you look upstream, you recognize that it's the structural setups of our societies. And that's where public health is really working towards, is how do we get at the underlying drivers of health, not just telling people eat well and exercise, but how do you build communities and economic structures that enable people to live safely, eat well, be active. So those are one main of the main drivers of the inequities we see, whether it be racial, ethnic, or geographic disparities that we see in the rural areas.
Thank you so much. We're going to move to our second speaker. Please stay on board, as we will have probably continuing questions you might be able to address on the chat as well. Our next speaker is Carmen Estrada with the Inland Valley Caregiver Resource Center, serving the Inland Empire. Carmen, thank you for joining us.
Yes, thank you so much. Good morning, everyone, and thank you for the invitation to have Inland Caregiver Resource Center share what it's doing to meet the needs of Californians' underserved rural communities as our population ages and grows. My involvement with caregiving and specifically caring for someone with Alzheimer's started at home. My mother was caring for my grandmother who had Alzheimer's when I actually began working for ICRC. And really the desire to learn more about the illness and how to support my mom is what sparked my interest in working with the agency. So although this is the work that I do, it is also very personal. ICRC is a nonprofit organization that provides services to informal caregivers and seniors in the counties of San Bernardino, Riverside, Inyo, and Mono counties. We are a part of a network of 11 caregiver resource centers across the state of California. So wherever you are in the state, there is an agency available that provides support to informal family friend caregivers. ICRC has been providing services in the community for over 39 years. Our mission is to help families and communities cope with and manage the challenges of aging and caregiving. Some of the services that we provide to both caregivers and the people that they care for include family consultation, counseling, support groups, training, respite. Our services are free. We do cover a huge geographic area with many rural communities. And each of these very different communities is very diverse. So there is no two rural communities within our region that I can say are alike. We have a high desert in the Victor Valley area, and we also have a low desert in the Palm Springs area. Both areas are considered deserts, both very different. So as an agency, we really have had to be innovative and think out of the box to try to reach the array of people across, our multi-county region. And we have done this in 5 ways because outreach is important. But first, we use word of mouth. In rural communities, we mostly find that individuals are very close-knit. Outsiders are sometimes not welcomed. Us having an office in the city of Colton and in the city of Hemet, obviously we're not able to have an office in every rural area. So word of mouth is important, encouraging current clients to share the information about services available to those caring for individuals with Alzheimer's is important. Ongoing outreach is also important to foster trust. It's not just about dropping off a brochures at a community center or at a church, but it's that ongoing outreach to build relationships and to collaborate. Fighting Alzheimer's, supporting caregiving, it's a community effort. So we have to build on that ongoing outreach and build collaborations. We also have to collaborate because, one of the services that we do provide is respite to give caregivers a break from caregiving. So we collaborate with a lot of different in-home care agencies across the many areas that we provide services in so that we can reach the individuals in all of the areas. And we also have to offer services in an array of options. So not just in person, but over the phone, via Zoom. With the pandemic, we were really pushed to move into telehealth, which has been beneficial. And which has allowed us to have the opportunity to offer services in various ways. And lastly, and I would say most importantly, we take the time to learn about what the community needs. And this is what takes a lot of time. It is very time intensive. But what I mean by this is we learn and we ask, how does the community want to receive the information? What is their understanding of the information we are trying to put out there? Specifically with topics like caregiving and Alzheimer's. How do they see themselves? We take off our provider lens and we try to see and provide services through the lens of those receiving services. And sometimes as providers, we don't do that. We think that we translate this one document in many different languages and that will suffice. But no, we really need to sit down and take the time, especially in our rural communities, to learn how people want to receive this information. We do this through listening sessions and focus groups. And like I said, it is time consuming, but it is very worth it. We recently worked on creating a hospice toolkit targeting the Latino and Hispanic community, and we used listening sessions to inform our project. And I will tell you, as a service provider, I went in with many misconceptions. I am Latina Hispanic, and in my thought and my view as a provider, I thought, well, Latinos don't want to talk about hospice. But it really depends on how you approach the topic, and that's how you get people to talk about it. That's how you get to learn how they want to be approached when it comes to things like hospice, end-of-life care, Alzheimer's, caregiving. So that's really important. Translation. Everything, my misconception was everything needs to be translated word for word. But for example, with something like hospice, the word often used translated as hospicio, which does not mean hospice, right? And this is the same when we're thinking about caregiving. when we're thinking about Alzheimer's, what are the words we are using to reach the community, to inform the community about these different topics? Another misconception I had was a flyer will suffice. A nice flyer put together with the information, that's all we need to reach the community. No, the community wants to be reached in different ways. We're talking about flyers, we're talking about radio spots, we're talking about videos and commercials. One of the things that we heard in our listening sessions is, why am I not hearing about this on the radio? Why am I not hearing about this or seeing this on TV? We see a lot of commercials about the medication out there for illnesses like Alzheimer's, but we don't see videos or commercials about what Alzheimer's is, about caregiving, about how to help each other. So it was a very informative project, and we created this toolkit, and we're using those lessons learned now to inform other outreach opportunities that we're engaging in. Someone asked specifically about the master plan on aging and how that is incorporating Alzheimer's and possibly even caregiving in the plan. And so for the state, there are 5 goals. The first is housing for all stages and ages. Second goal, health reimagined. Third, inclusion and equity, not isolation. Fourth, caregiving that works. 5, affording aging. And so although the state plan does not specifically mention Alzheimer's and related dementias, Alzheimer's is interrelated in each of these 5 goals because, as Dr. Nguyen was saying, structurally, everything kind of connects. And your lack of access to healthcare is going to impact when you get a diagnosis such as Alzheimer's. So the state plan has these 5 goals. And one of the things that it has recently done in collaboration with the SCAM Foundation is put out proposals for communities, local communities, to form their own local master plans, which I think is extremely important. ICRC is part of the Inland Coalition on Aging, and currently we are working on our own local master plan in which we do highlight Alzheimer's and related dementias and caregiving as one of our main domains. We used the same process as I just mentioned with listening sessions to really learn about how our community, specifically the community living in rural areas, what they thought about Alzheimer's and dementia and caregiving. And like Dr. Nguyen mentioned, there is a lack of information, but there's also a fear about talking about these topics. So in our discussions, we found that people were open to talking about Alzheimer's or even caregiving as it related to others, but not themselves. Not themselves seeing themselves as a care provider, especially in our different ethnic communities, but also not themselves as getting or having memory issues.
Carmen,
Yes.
I'm
Sorry.
going to have to, just because of time, this is a wonderful presentation. I want to ask you one question before we end and move to our third speaker. What are you most worried about, and what are you most hopeful about as somebody right on the front lines of dealing with these challenges for healthcare for people with Alzheimer's?
What I'm most excited about is obviously all the research that, the findings that are coming out with regards to Alzheimer's, the opportunities to create more medications, different medications that are going to help families. I'm also excited about, the local different areas having the opportunity to create their own master plans on aging and the state's support of that. What is, a little bit more daunting is the fact that, our population is growing. In the Inland Empire alone, there is a projected 685% increased growth rate in individuals 65 and over by 2060. Our infrastructure is definitely not ready for that. But we are hopeful that with the creation of our own local master plan, we'll be able to, address some of these findings and recommendations that we found through our work.
Thank you so much. And please, if you can, stay on, look at the questions in the chat, and we will have a final Q&A period for all our speakers. Thank you so much for joining today. Our third speaker is Maria Cortez, who will share her experience as a family caregiver for her brother, who has Alzheimer's and lives in Glenn County. Maria Cortez, thank you for sharing your perspective on this topic.
Thank you all for inviting me to this forum. I would like to say a few words about Jerry, my brother. I have been his caregiver for the past 3 years. He is now 62 years old, but he was 59 when he was officially diagnosed with FTD. Of course, that's frontotemporal dementia, a progressive brain disease that we were told, according to his neurologist, the front portion of his brain progressively will shrink. And he has been apparently seeing how rapidly it's advancing. Before his symptoms and his diagnosis, my brother was a very strong, cool, collected person, very responsible, hardworking. He worked for 32 years for a company out of Willows in Glenn County. He ended up, before that, he had already been divorced for a couple of years. After that, everything was just going downhill. He lost his job, and he used to drink moderately. After he got fired, his drinking got a little bit heavier, according to family members. And all this information was given to me because at that time, I was living in Texas with my family, and all my other siblings are here in Glenn County. So they would try make contact with him after he had been fired. He was living on his own and showing symptoms that nobody knew what was going on. Some of them were they noticed that he had become verbally abusive to people. Brothers and sisters would try to go visit him and find out, what is going on. He would just get into a scream match and just start cursing for no apparent reason, just telling you basically go away, go fly a kite, but not in such words. So we were all kind of just trying to find out what is happening. Things that he was doing that were not normal. A couple of things. I was told that one time he just started driving, not knowing where he was going, ended up in San Diego, called someone from the family, and they told him, well, you need to get back. What are you doing over there? He said, I don't know. So thank God he was able to drive back safely. But on another occasion, he did the same thing, ended up in somewhere near Reno, Nevada, and he apparently blacked out and had an accident. They called my brother, and he went and got him. His car was totaled, and just things like that were out of the normal. And all these symptoms were going on. He was living by himself. At that time, he had moved into our parents' home. And unfortunately, he has chosen some not very nice friends. They were kind of shady people. And I guess they saw the opportunity of what was going on with him. He was not making right decisions. And so they decided to move in with him. They ended up taking over the home, his bank account. They called me when I was in Texas, and they said, look, he won't listen to us. Maybe he'll listen to you. So I decided to take a trip up here and have access to the house. And the conditions that he was living under were just horrible. I mean, terrible. They had him in the rear bedroom, living basically worse than a dog, worse than an animal. And all these other people, they had just taken over everything. So what I could do at that point, I was just wanting him to be pulled out of that environment, and I took him back with me to Texas. I could only keep him away there for a couple of months. He was very upset that I had taken him away. And I actually told him that I was only going to take him for a week. That's the only way that I could, take him with me. But we ended up coming back. My husband and I at the time had agreed that I would come back and see if I can get those people out of the home and try to get him some help, which at that time it was during COVID, and the people that were here, it was very hard to get rid of. 3 of them, actually, it wasn't that hard, but one of them, I guess he knew the system. He played the system all his life, and it took us about 3 to 4 months to get him out of here and evicted. But keep in mind that at the same time, we also were dealing with our mom's health. She was at that time in a nursing home. She was 97, and she ended up passing away, and having to deal with that. And then my brother, not knowing what was going on. So what I did, I had already moved here. A challenge that right away I kind of ran into was, because it was all new to me, trying to get him help filling out the forms to get him Medi-Cal. And at that time, he really didn't have any money left. And so that kind of took about a month, because just, if we remember back during COVID, everything just kind of like took longer than the usual. So it was maybe like about a month and a half to get him approved for Medi-Cal. He was approved. Then I found him a primary doctor. Once he got that, he got referrals to get an MRI. We told him the symptoms. We actually guessed what we thought might be going on. I had told the doctor, I said, I don't know, he might have had maybe like a stroke, and maybe that's why he doesn't remember things. He just takes off driving. He doesn't know where he's at. He was having blackouts. And so he had the MRI done. And then I got referrals for a neurologist. Another challenge was that I couldn't get an appointment for him to see a neurologist nearby. Chico is only like 10 miles away from us, from where we live in Glenn County. But instead, we had to drive 2 hours to Sacramento and 2 hours back. There's no medical help attention to see it. It's like a psychiatrist, psychologist, neurologist, nothing like that nearby. Everything is so far away, so that was kind of hard to deal with myself personally. I'm older than my brother. I'm actually 66. So, the driving, sometimes the appointments during the winter, they wanted them early. So that meant that I had to take off like maybe 6, 7 o'clock when it's still dark and I can't see very well. And then, or maybe driving back. So I always had to make sure that I was given an appointment where it was kind of like in the middle of the day, things like that. Other challenges was, I thought to myself, everything was just happening so fast. His symptoms, just, it was 2, 3 things, that was going on. And then maybe next month, something else was going bad. Like first she started with the memory loss. And then we saw anxiety. And then he developed hallucinations. And then it was depression. He lost empathy, no clue of personal hygiene, unable to feed himself. He had to be monitored. He has to be monitored on what he eats every single meal. He needs assistance dressing. Now, another thing that just happened within the last month or two, he can no longer bathe himself. That challenge was a bit strong for me, because him being a male and me a female, being his sister, it was kind of tough on me. It was difficult. It was very difficult. But
So,
I said, okay.
Maria, this is such an amazing story of your assumption of responsibility, what would have happened if you could not have given up your home in Texas and moved back to Glenn County to take care of him? What do you think would have happened to him?
He would have been dead by now. He wouldn't be here. He would not be here. I think the conditions that he was living under with those people here, and I think we believe there was drugs involved as well. He was not eating at all. All he was eating was bags of chips. I remember that. I think that was why he was having blackouts.
And how do you support yourself? Where do you find the most important community support for this devoted service you're providing to your brother?
Well, I'm glad that he was able to get Medi-Cal, where his medical appointments, doctors, and all that are covered. I'm semi-retired. I still work from home with my now ex-husband. I ended up getting divorced, partially because of this problem. My husband claims that I prefer my brother instead of him, but we already had other problems before this. But anyway, I'm semi-retired, so with my income and his retirement that he now gets, and his medical insurance, that's how we get by.
And in terms of an agency, we were referred to you by an agency in Butte County. And I just wanted to ask you, how helpful is it for you to have the Peg Taylor Center for Adult Daycare Healthcare?
I have that on my notes. They are wonderful. He goes twice a week, sometimes 3 times a week, and it's from 10 to 2 o'clock. And that's my time that I can say, you know what, I can catch up on this, I can do this, I can go out and, buy whatever I want, without having to. My brother right now, he's at the stage where he's like a 3-year-old in a grown-up adult body. But they are wonderful. That program is wonderful. It's the only one that I know of. I had looked and made, I had other referrals that I was, when I was looking for a program like that, and that I know of with memory loss, such as my brother's. That's the only program that I know of, and they are wonderful.
Thank you. I just find your story so moving, and we just want to say how much we respect the care you provide your brother. I want to ask Dr. Nguyen, to what extent are adult day care centers like the Peg Taylor Center available in rural areas? Do you know, Dr. Nguyen?
Our rural communities are so diverse and throughout the state. It is hard for me to say in any given community the density and prevalence of adult daycare centers. So that wouldn't be one that I can address accurately to have an assessment of how many and where they are.
Great, and maybe I'll send in a chat question to Kendra Adcock. But thank you so much, Maria Cortez. We're going to move now to our last speaker, Hagar Dickman, Senior Attorney with Justice and Aging, to ask you to share the results of the research you've been doing on barriers to care.
Thank you. And I just really wanted to thank Maria for sharing, her experience as a family caregiver. I think it's so important that what came out from this research that we did is just how important it is to have a family caregiver in your life, especially when you have Alzheimer's or dementia. Just wanted to introduce myself and my work. I am a senior attorney here. I work on California's long-term services and supports and home and community-based programs in California with a focus on the Medi-Cal program, which is California's Medicaid program, so that older adults can age in place. And because Medicaid is the largest payer of long-term care, access to Medicaid services is really essential for individuals with long-term care needs. So we really focused our study here on Medicaid, access to Medicaid programs. The project was focused on identifying barriers to personal care services for individuals specifically who can't direct their own care and don't have family caregivers under Medi-Cal. So, and that came out of a recognition really that having a family caregiver is a resource that there's a portion of the population that just doesn't have. And that's really a necessary resource for people who can't direct their care. California's largest program for personal care for low-income adults is the In-Home Support Services Program, which serves 700,000 individuals and is really an essential program for keeping older adults and individuals with disabilities to live in the community and stay out of nursing home care. It's a self-directed program, which means that consumers have to find and hire and supervise, and if necessary, fire their caregivers. And 70% of IHSS users actually have a family caregiver. So looking at that program and access by people who can't direct their care, like individuals with Alzheimer's and who don't have family caregivers, is really important. And then we also looked at other access to other California Medicaid programs, including the CBAS program, which Maria talked about, assisted living waiver program and HCBA, and then the programs available under Medicaid managed care that provide personal care services. We held over 80 focus groups interviews and interviewed over 100 individuals in a wide and diverse scope of folks statewide about these barriers, and found consistently across the state that low-income individuals with mid to late Alzheimer's and dementia really have no community care options, are unable to access the IHSS program or other personal care programs, and face particularly significant challenges in rural areas. And we also found that there are significant ramifications for unmet needs for individuals with these conditions. Going without care, individuals with dementia and related conditions have to go into institutional care or die in hospitals or at home. And the impact, from what we heard from people in rural areas, is felt so much more in these rural communities, where we know there are less medical services and nursing homes, fewer caregivers, and especially those trained with dementia care, and no transportation options. And if you think about the type of services that individuals with Alzheimer's need to remain in the community, those services need to adapt with increasing needs. So in California, we have, the IHSS program, which provides self-directed personal care services. And then we have CBAS, which is the adult day health program, and then assisted living waiver program, which is really like the Medi-Cal assisted living program. All of these programs require infrastructure, whether it's caregivers or adult day health centers or residential care facility for the elderly, where people receive assisted living services care. What we saw in the interviews is that individuals with Alzheimer's or dementia who don't have family caregivers have a really hard time navigating through the IHSS program, both in the administrative hurdles that they have to go through to enroll in the program, and also in the hiring and managing of a caregiver. And that difficulty gets worse and gets more difficult with cognitive decline. And so even those who find caregivers at a certain point can't get enough hours that they need to keep them at home. And then other programs like the assisted living program has such long wait lists, around 3,000 individuals, that it's really impossible to access. And that program is available only in 15 of California's 58 counties. Even CBAS, I think, to answer the question before, I believe is available in only 22 counties. So it's a wonderful program, but it's really limited to only about.
Could you remind us what CBAS refers to?
Yes, it's the community-based adult services program. Okay. It's the adult day health program. And I put the link, I think someone asked about the centers. I don't know if there's a map of this to show density, but I did put a link in the chat for the list of CBAS providers in the state. And CBAS, that program is also underfunded. And so it's going we've been seeing since the pandemic, a lot of centers actually closing. So in rural communities, like I said, there are very few, if any, of these programs, especially up in the northern counties. And then, as I mentioned before, because rural counties have a density problem, people often live just too far away from the service or from an available caregiver. And because the transportation doesn't exist to help them to get where the services are, they really can't access them. There's also a shortage of skilled nursing facilities in rural areas, so people really have nowhere to go in their communities and either have to choose to stay in their home or to move out of their community to access skilled nursing. What we heard again and again from those supporting community living for individuals with these conditions, whether it's social workers or service providers or community-based organizations, is that especially in rural areas, they struggled in finding any kind of support for individuals that came to them for help once the Alzheimer's or dementia advanced to mid to late stages of the disease. And often in despair, they were calling adult protective services to step in, even though adult protective services really can't do anything to assist in these kind of situations. They reported seeing increased levels of neglect and injury, eventual hospitalization, institutionalization, and death, either at home or in the hospital. So what came to, and then out of this research, what became really clear to us in talking to rural participants versus participants in other parts, more populated parts of the state, is that many policy solutions that may work in urban areas really are not appropriate for rural areas because of these density issues, lack of providers, and lack of service. So any kind of policy solution that would work to address the needs of individuals with Alzheimer's who don't have family caregivers in urban areas might not work in a rural area just because of the lack of infrastructure. So I thought I'd leave it there, and then I can answer questions or.
Your study is also aimed at recommending where you see the best opportunities for addressing these challenges. What 2 or 3 sort of strategies did you find, or are you thinking most important for justice and aging to advocate for?
I think there are several. I think the first thing we need to look at is the IHSS program as the main provider of personal care services in the state, and looking to see, well, if it's a self-directed program that really works well for individuals with family caregivers and some disabilities, some conditions, and it's really not working well for individuals who don't have family caregivers and can't direct their care. And so, like, what do you need to do to that program to bolster it and make it accessible for individuals with particular conditions or living in particular circumstances? And one of the things that we are thinking through is having a sort of agency mode option for IHSS. And that's a very complicated thing to add to IHSS. So it's not, I don't want to, take you too deep into the weeds, but
Right.
really making sure that the IHSS program works for both individuals who are able to manage care and those individuals who need to go through a home health agency to find a provider. That would go a really long way to make that program accessible for individuals who can't really go out and hire and fire and manage their own caregiver. Other things, I think that particularly for individuals with Alzheimer's and dementia, there is a need for intensive case management that is not available in IHSS. It's just not a service that's available in the program. It's available through CalAIM, through the enhanced case management, but that particular service we haven't really seen that it's working for individuals with Alzheimer's in the way that it's needed. It really needs to be coupled together with the service. So I think looking at making intensive case management available for individuals with Alzheimer's and dementia would be another policy direction that we're looking into. And then I think, there are a lot of integration models that integrate housing and services that I think work, especially in urban areas. And I think thinking through how those kind of models would need to look like in rural areas is going to be very tricky. I think the one thought is expanding the assisted living waiver to be statewide and have the infrastructural investment to have these residential care facilities for the elderly, be more available in rural areas would be one solution.
Well, great. I realize you're bringing us back to the whole purpose of Take on Alzheimer's, which is really to put it on the radar as a issue that is central to the health and well-being of a growing population, very rapidly growing population of older adults, and that perhaps it's always easy as a journalist to say the most vulnerable, but let's just say today's briefing is all about spotlighting the challenges for Alzheimer's, people with Alzheimer's disease and cognitive decline, to access care in remote rural areas. So thank you for taking us a little bit into the more policy-oriented aspect for those of us who fully intend to continue covering this very important part of healthcare. I want to now go back to each of our speakers and ask a final question. And let me, my question will be, first of all, starting with Dr. Nguyen, looking at the role that Take on Alzheimer's has really embraced, how do you see it affecting particularly this population we've focused on today in rural California? What would you say is the most important for us as journalists to understand about the relevance of Take on Alzheimer's for rural residents with Alzheimer's?
Two of the main goals of the campaign were to raise awareness of Alzheimer's campaign to enable people to prevent and treat it earlier and to reduce stigma. And I think this is doubly important in rural areas because early recognition and diagnosis is particularly important in areas where it may be harder and take longer to seek care. And so these are reasons why rural communities in particular, we want them to know about Alzheimer's disease. We want them to feel empowered to recognize the signs and symptoms and then to seek care and do the things to prevent Alzheimer's from progressing and starting as well.
And how do you see that this very important challenge for all of us, early recognition, overcoming our own fears of talking about this illness, reaching out, connecting with people, building a community resilience, if you will, around this area? Give us a hopeful note as a clinician about what Carmen Estrada said was one of her excitements, the progress being made in treatments.
Yeah, actually, when I speak to patients about it, I like to start the conversations from a place of empowerment and hope that I'm having these conversations and asking these questions because there are things to be done that I want folks to know and to recognize, and then be connected to all the resources. And yes, there are everyday advancements with Alzheimer's knowledge and research. We have more medications. We see which medications are more effective. And so the whole point, the whole reason to know earlier is to actually do something about it. And that's what we want folks to know. That's why we're having our first ever statewide campaign to elevate the importance of the issue, to recognize it, to not be afraid of it, but recognize that it's the first step to actually doing something about a diagnosis.
Thank you. And thank you for your great responses on the chat, which we will be sharing with everybody in the collateral material we send out. Let me go to you, Carmen, and especially listening to our other speakers, the experiences Maria Cortez related, the findings of the research by Hagar Dickman, and the important perspective offered by Dr. Nguyen on early recognition. How do you see your center adapting and navigating through what is clearly a growing and critically important challenge of rural Alzheimer's patients?
I think collaboration is important. I also think that, we need to, as a community and within ourselves, embrace aging. Caregiving, Alzheimer's are topics that relate to aging, but really it affects all of us, and we are all aging. And so I think personally, we have to start thinking about aging as it impacting us at every stage, not just at the latter stages. If we can do that within ourselves, then we can do that as a community and be more supportive of one another when we are facing challenges with caregiving and also with illnesses like Alzheimer's.
And for you personally, the Take on Alzheimer's campaign is all about raising visibility, a state communication drive that is focused on Alzheimer's. How do you see this reinforcing the work you're doing?
Well, I think it's great when you get the support of the state. It's more resources that they have available than, my little nonprofit that I work with. And so the fact that the state is taking those steps and highlighting it is extremely important, and that it's also being intertwined within the governor's master plan on aging. So those are all very positive, and it helps support nonprofits in the work that we do, because then it creates more funding opportunities, more resources to expand on the work that we are doing.
Very good point. We're over time, so I'm going to ask our last two speakers to limit to 60 seconds your response to this question. Maria, what is the most fulfilling thing you find about being a caregiver?
At this point, I helped my brother be alive for however many years he's got left, hopefully many to come. But like everybody talked earlier, learn the signs and get help. Try to find out what's going on. We didn't know for a couple of years, and maybe that could have helped him or helped somebody else detect early.
That's very inspiring. And for our last speaker, Hagar Dickman, what are your next steps? What is Justice in Aging hoping to do as a policy advocacy organization
around this project? I think, well, the next thing we're going to do is compile a report and have some concrete policy recommendations that we're going to take back to our stakeholders, the people who participated in this study, and try to come to a consensus around how do we move forward, and how do we really fight against the assumption that we have as a society that people with Alzheimer's can't live at home. How do we build a home and community-based service, that program or system that really addresses the needs of all individuals and all aging adults, regardless of cognitive impairment or disability status.
Thank you very much. It reminds me of the opening mission statement of the Department of Aging when they announced their master plan, which was fight ageism, the tendency to dismiss the value of older people's lives because it's end of life. And I think today has been such a illuminating briefing. I want to thank our speakers, our media colleagues, and our interpreters for joining us today. Thank you. We have to end because we're over time. Very grateful to all of you.